just to correct Larry a bit, we came here in '79.
Oh.
But hey, who's counting a year at this stage? And you can see I didn't shave this morning, or I did shave in that picture. And the title, as I say, in silico fishing, and the fishing is sort of part of my relationship with Art Cherkizov. Now, he's a colleague that we hired about 4 years ago, I guess, in the lab. And one thing that Art has really shown me how to do is fish. And so this was caught in the Vedder in Chilliwack on an expedition, a fishing expedition with Art a couple of years ago. So what I'm going to talk about is the development of a whole new class of drugs. And we're very excited about this, and it really shows, I think, the synthesis between sort of a chemist, and that's Art, and a biologist, that's me, and a fish. Why is it not working? Hey, Max.
That was a great talk.
Yeah. So, okay. So the topics that I've elected to speak on, natural history of prostate cancer. Well, most of you will know that, so I'll just glean over that. Anti-androgens and androgen receptors. While many of you are familiar with anti-androgens, you don't perhaps realize their structure, and I think there's an important feature there. Then I'll move into the in silico fishing component, and this is using computer technology and virtual modeling to find new anti-androgens. I will focus on the fourth topic, which is targeting a site called the BF3 site, and I'll explain what that means in a moment. And finally, I will end with some very new data dealing with inhibitors to treat these constitutively active forms of the androgen receptor. So we're trying to cover every base here. So I was asked to provide learning objectives. I don't know if you already know these facts, but the continuing role of the androgen receptors in the growth of castration-resistant prostate cancer. Castration-resistant prostate cancer, you probably know what that means, but basically it's prostate cancers that reoccur under treatment with anti-androgens or forms of androgen withdrawal. Second, using computer modeling. I think this is a new area. It's new to academia. It's been used to some degree in big pharma, but to do this in an academic setting is quite new, and we are fortunate to have one of the world's experts in our lab. And finally, the development of the new drugs that inhibit this constitutively active truncated form of the androgen receptor. And you may or may not be aware of the existence of these entities, but I will make you. Okay, prostate cancer. In North America, it's the most commonly occurring and the second most lethal cancer of men. Maybe you can correct me on this figure, but 30% of prostate cancers recur after surgery, and approximately, and subsequently are treated with androgen withdrawal type therapies. This is often LHRH agonists or anti-androgens or abiraterone. Once this reoccurs, it's not really curative in the metastatic form, but it can be held in check for a long time until the tumors become castration resistant. And at that point, the median survival is approximately 18 months. And importantly, for our whole focus on targeting the androgen receptor, is that the receptor persists in most cases. More than 80% of cases of castration-resistant tumors have an androgen receptor. So the signaling is still going on, it just no longer requires the androgen. So this is a very horrible slide, and I would never even pretend to take you through it all. But the salient features, of course, if I can get the arrow to work, which I can't. Anyone have a PC in the room? At any rate, the point is, I guess I can't straight, that the androgen receptor has a lot of interactions with other signaling and growth factors in the cell. It doesn't just stand alone. It is in the form of an inactive complex with heat shock proteins and so forth until it sees an androgen. When it sees the androgen, it then uncouples all these, activates, and forms a dimer, and is drawn into the nucleus. Now, it's not clear whether it goes in as a dimer or dimerizes in the nucleus. Once in the nucleus, it binds to very specific consensus sequences on the DNA, and this causes the recruitment of a lot of proteins. These are called co-regulators, as well as the so-called transcription machinery, which then turns on a series of genes, or turns off genes in some cases. Basically, the androgen receptors contain a domain structure, and that domain structure consists of an N-terminal domain, which is very large. In fact, the protein itself is a very large protein. It's 110,000 molecular weight and has about 919 amino acids, okay? The biggest part of the domain structure is the N-terminal domain, which has an activating function in it. The next adjacent domain is the DNA binding domain, which is responsible for, specifically binding to sites in the DNA to turn on genes, okay? Then there's a hinge region, which has the nuclear localization signals, and then the ligand binding domain, which has, as the name implies, the sites for where the androgen binds and where all the anti-androgens currently used bind. They bind to the same site as the androgen, okay? And that's how they've been modeled. Okay, so this is just what I was saying. I'm almost afraid to touch this thing, but you can see the domains that I spoke of, and the structure in grayed out somewhat here is the ligand binding domain, that gray piece, in the three-dimensional structure, okay? And where that black bit is where the androgen or the anti-androgens bind. And this is the existing clinically used, or previously clinically used in some cases, anti-androgens. Flutamide was the first one. And these molecules all compete for the androgen to bind to that one site. Okay, that's their primary mode of action. Now, they also have other actions. They can prevent uptake and so forth, but they bind to the same site as the androgen, as DHT. Now, to a non-chemist like me, they all look quite different, and but they have different activities. Like the one that has been used consistently is bicalutamide or Casodex. The metivation compound down at lower left there. I'm afraid to use these arrows. Sure.
So, at what point in the beginning of binding? Is it before?
It's right at the very beginning here.
So before the shock.
I don't want to use the arrows because they.
Before the heat shock proteins and other chaperones.
Well, the heat shock proteins are all sitting there, but the site is exposed enough for the androgen to bind. This causes them to peel off, let's say. Okay, and that's the way it works.
And
the anti-androgen basically competes for the androgen. In other words, it can prevent the activation, but it may also bind and cause other factors too.
What does it do with all of the chaperones and co-regulators?
It may recruit co-repressors. It doesn't allow some of the co-regulators to bind, but it may allow them to bind as well. I mean, it's a very complex thing. The basic fact that it binds in this site means that the androgen can't bind there. So that's the primary thing. The secondary thing is it changes the shape of the receptor slightly and doesn't allow some of the other proteins to bind that are necessary for the activation. Okay, so all of these things, and the metivation one is now called enzalutamide. I'm sure you've heard of that, and it's the most potent new anti-androgen. But it's interesting. They're all basically built on the same molecule, and not surprisingly, when resistance arises, they all become resistant. Charles Sawyers, who has been responsible for developing the metivation compound, recently published showing that a common mutation prevents them all from being active. And so it's a vulnerable site, but they work, and they work for quite a while. However, how do you deal with the resistance? And so to address that problem, we've looked at alternative sites on the androgen receptor. Now, these are non-conventional sites because, as I say, the only site that has been targeted by drugs that are clinically used is the androgen binding site. So what we set out to do is to use an in silico approach. In other words, use computers to virtually model small molecules for other sites on the androgen receptor. And I'd love to use the arrow, but I'm afraid. You can see that underlined novel. Dare I? Okay. So novel surface sites. So what does that mean? Well, I'll explain in a minute. Now the reason for doing this, the real rationale for doing any of this is that, I've lost the arrow, is that cross resistance. We want to overcome the problem of resistance, and our compounds, if they work, should not have cross resistance because they're targeting a different region. Now I've mentioned where the androgen binding site is, and here it is there. And we've targeted, although I'm not going to talk about it today, this activation function 2. This is a site where co-regulators bind, or a lot of them bind. And we have done some work on this, but we found that we were unable to develop really potent anti-androgens, the things that will inhibit the androgen receptor. We may go back to that, but the one that we've focused on is this one, the binding function 3. This was first reported by Robert Frederick about 6 years ago, where he screened a wet library. And I think it was about 15 or 20,000 compounds in this. And it's a tedious process. You add the compounds, see if you get binding to the androgen receptor. Then you figure out where the binding is, and then you figure out whether it inhibits and so forth. He screened about 15 or 20,000, came up with 4 molecules that seemed to have activity. 2 of them proved to have real activity in around the 10 micromolar concentration range. Okay, so this was our start. We thought, well, we can do better than this. Especially Art had just joined the lab, and he had a hammer looking for nails, and I said, here's a nail. Let's start hitting this one. And so he brought with him at the time. He was working with infectious diseases before he joined us, and he had an arrangement with a cancer agency where he was able to link up with their processors as well as our own. And so he has, in a tandem fashion, over 250 processors at his command at different times of the night or day or whenever he uses them. And you need that sort of horsepower, computer horsepower, in order to do what he does, and I'll show you. So what he does, he catches big fish for a start. Now Art is only 2 feet tall, so no. But he caught a very large fish that same day, and obviously had to show it off. But it's amazing. Anyhow, when he's not fishing, he does his in silico fishing, and the way it's done is you use what's called the Zinc Database, and it's a database of virtual chemicals. In other words, you've got they're annotated virtual chemicals, and the computer does all of the first steps. It does the first algorithms. These are all different algorithms for fitting into that 3D model that I showed you. Okay, we identify the site, and now they try to fit them in virtually using the electronic configurations and so forth. And if I ever do this right, I'll be lucky. They're virtual, but they're virtual. We're not testing them wet. They are just electronic configurations representing the various chemicals. Now these chemicals, these 10 million chemicals, are from everything. They're from nature, they're from effluents, they're anything. It's an amazing database, and is designed specifically for this purpose. Anyway, at the end of the rainbow, forget it, we do a visual inspection, or they do, and literally put on 3D glasses, and you have software. And this has been a very impressive toy for raising money. Because when we have visitors and we have them put on the glasses and say, oh wow, I can see the molecule, and place things in, this is very attractive. Anyhow, this is what we do with the last 1,000 or so. In this case, this was the very beginnings of this study, and we had acquired some money from Safeway Canada to do it. And so we ended up with about 200 compounds. And then we have to obviously do the biology to see if they really do fit. This is, don't ignore the writing on this. The only reason I'm putting this up is to show you how they fit. Now, when we have chemicals, we can do this in a visual manner with the 3D glasses. But what we've done, when we had the candidates, and these are just likely, possible, potential molecules that may bind to this BF3 site. We then do the, measure the activity, and we use principally two ways to do it. The first is a transcriptional assay, which I'll give you a little more information on, which allows us to screen hundreds of molecules, and that's the value of that. Then we look at the effects of our compounds on the secretion and production of PSA in these cells. Okay, this is endogenous. We're not wiring that in. And then we look at the binding aspect. This is called BLI, and I'll explain that in a moment. So these two components are essential. We have to show activity, and then we have to show binding to the androgen receptor. And then if those criteria are met, then we go in to do the cell proliferation, and then the ones that don't bind to the androgen binding site but are active in inhibiting cell proliferation, we then push them down the chute to do medchem. Okay, so that's the overall procedural outline. Now this is an assay, or the concept of the assay, that was developed by Payman Tavasoli, who is currently a resident in pathology, and he did his PhD with me, a very bright guy. Basically what we do is we build into the cell and this is like a permanent feature of the cell now, is that it has the capacity to express a fluorescent protein, EGFP, when stimulated with an androgen receptor. So if you add androgen, then you get a bright green cell, and this can be quantitative. Now the joy for us is that if we add back different anti-androgens or things that interfere with this, we can get a linear fashion of a measure of how effective these molecules are. And this is a compilation of several hundred that were tested, but you can see anything below that line are things that have an effect on inhibiting the androgen receptor. Only the ones right at the very bottom are the ones that we bother about. But it's interesting that our hit rate, I mentioned about Robert Flederic's screening of a wet library and seeing a hit rate probably of 0.001%, if that. We're seeing 10 or 15% using this in silico approach. So it's a very powerful tool. Now, how do we measure the binding? Well, there we want to measure this in hundreds of compounds. We just don't want to measure it once. So to do that, we acquired this machine, FortiBio Octet Red it's called, which does biolayer interferometry. What does that mean? Well, basically you have hanging down on a very thin gold filament recombinant pieces of your androgen receptor or whatever protein you're interested in. You put through your chemical, your small molecule. If it doesn't bind, it just goes by and gives you a flat line. If it does bind, even momentarily, it'll bind and come off, and you get an on and off rate as shown in this part over here. Now we apply that, so we have activity, we have binding, and again, these are our main criteria. Now this looks very complex, but I'll walk you through it. As I mentioned, we're measuring this transcriptional activity with the cells that Payman created. And if we look at the metivation compound, basically we can see it's quite active. And this is concentration along the bottom versus the amount of inhibition, or the amount of activity actually, and how much we're inhibiting the fluorescence. And you can see it's quite active. And now our compound, one of our lead compounds, which is referred to as 13163, is almost as effective, but not quite. It has the measure that you use for comparative purposes are these IC50s. This is the amount of compound required for a 50% inhibition. And we're seeing that the IC50 in this context is around 0.4 micromolar for our compound versus about 0.1 for enzalutamide metivation. If we look at endogenous PSA, our compound works at a level of about 0.2 micromolar, whereas again metivation is 0.1. So metivation is more potent in these systems than ours, but not hugely so.
You say that effects
Well, I'll get to that. At least, to be honest, we haven't done it in an analytical manner, but we do have an effect, as you will see. Okay, and so, but I'll come back to that in a bit. Now, this is the BLI, the biolayer interferometry, showing on and off rates. And what this tells us is that the small molecule, that in this case, that particular one, the 13163, is able to bind at different concentrations. Each layer is and fall off at a very fixed rate. This informs us that it's specific binding, and it's binding to the androgen receptor. It doesn't tell us exactly where it's binding, but it tells us it's binding to the androgen receptor. Now, if we look at cell survival, if we have PC3 cells, which are another prostate cancer cell line, but they lack an androgen receptor, and this is true for any cell lines, our compounds have no effect if it doesn't have an androgen receptor. So it requires the androgen receptor, naturally enough. And our compound, in this case, this one particular one, is quite effective in an MTS assay. Not as effective as inhibiting transcription or PSA, but we are seeing about 0.7 micromolar. This compares with the 10 micromolar IC50s that were seen by others, Robert Flederich in particular. Now, why are we doing this? Well, we're doing this because we want to have a new class of drugs that can deal with resistance. And Amina Zubaidi, working with Martin, was able to create a resistant line. The enzalutamide has just been FDA approved, okay? But already we have a resistant line. It's a LINCAP prostate cancer cell line that is resistant to enzalutamide. And so this is a great tool. It still has the androgen receptor, still produces PSA and so forth, but it no longer responds to enzalutamide. So it's a great tool for us to study our drugs. And this is the enzalutamide, which obviously it doesn't affect the cell's growth, or in this case PSA secretion. But our drugs work quite well. So this is what we were seeking, and all of them seem to work very well. So we see these as becoming the next generation of drugs to deal with the resistance. Now, but I'm just, and the panel below, I'm sorry, I'm having a lot of trouble with this arrow. It shows the effects on growth at 2 micromolar. Okay, so it's quite effective in that context of enzalutamide resistant cells, and we've tested that lead. I call it the former lead because we've got a new compound that's better, which I'll show you in a second. But basically, this 163 is effective, and what's shown here is is the comparison on tumor growth in a LINCAP model. These are xenografts comparing enzalutamide, or metivation compound here, versus our compound. Now, but we have to use a lot of compound to see this effect. So the PK values of pharmacokinetics are not great, so we're moving along with MedChem to try to improve on that. But in the meantime, the MedChem has given us a very, very potent compound. Now, you recall I was talking about 0.2 micromolar as sort of the range of effectiveness for IC50. This one is 4 nanomolar. So it's at least 200 times more potent, or 50 times more potent in that context. And it's far more potent than enzalutamide, which is looking at the, again, if I could get this is our transcription assay, this is our compound, which is more sensitive, and this is the enzalutamide. If we look at PSA secretion, the same pattern here. It's about, the IC50 is about 11 nanomolar. We show binding as we'd expect, good binding. And we can also, I'm just trying to figure out what that even says now. This compound is equally effective against LINCAP cells and the enzalutamide resistant cells. So it's a very potent, and this is at higher IC50, but this is, you'll recall, was something like 700 nanomolar for the previous compounds in this context. But this is a very potent compound that should enable us to do lots in terms of figuring out the mechanism of this, because we don't even know what the BF3 site does. We have no idea. We just know it's there, and we know if we fill that cavity, we can inhibit the androgen receptor. Presumably there's a protein binding there, but that's what we're trying to work on now. So this is our current lead compound. We're working to do medchem. We're working with a guy named Bob Young, and also this Ukrainian company. And basically, we're hopeful that we can make this a drug very shortly, because it's so potent. I mean, it doesn't appear to be overtly toxic to the animals. The animals seem quite happy when they get it. It has no effect on cells that don't have androgen receptor. So it's a good lead. We just want to make sure it works in vivo too. So I mentioned at the onset that people have reported a new type of androgen receptor. Actually, Rob Snook and I were the first to indicate that it was possible to truncate the androgen receptor and get constitutive activity. Finally, it's being quoted. And that was done in 1992. In about 2004, it was discovered in actual tissues that these truncated variants of the androgen receptor actually existed. And this slide shows you some of the, if I can get an arrow key here, shows you some of the splice variants. And what happens, in most cases, these are translated as the full length, and then they're spliced into smaller pieces. Now these smaller pieces can coexist with the full length, and that's often the case, or they can act by themselves, although that's less seen and still controversial. Nevertheless, these smaller pieces contain the N-terminal, which has a constitutively active activation function, which means it can turn on genes, perhaps the same genes, many of the same genes as the full-length receptor. It can turn them on and not require the androgen. And it's totally, since it lacks this ligand binding domain, which is totally absent, it's immune to anti-androgens. So it's a constitutively active form. Some people believe, the proponents believe, that this is a main cause of continuing androgen signaling and being totally refractory to any kind of anti-androgen. And so, but the other side believes, Charles Sawyer is amongst them, believes that it's sort of an artifactual thing, and that it always requires the full length and so forth. At any rate, we decided to see if we could target it. So well, I guess I can show you a little more data about it first. First of all, the evidence in support of this being anything is that in some patients, the PSA-free survival, whatever that means, is connected, or at least related, to the concentration or relative number of these variants. And so the green line shows if there's a relatively low median number versus the red, which shows that if there's a high number, then survival is compromised. So this is the type of data. Now, I would hate to have to defend this data because it's got all sorts of holes in it when you look at the paper, but the general concept seems to be true. Also, another piece of data from another lab shows that the number of splice variants goes up with metastases, or at least is more prevalent in metastatic samples. Again, is it an innocent bystander, or is it the causal entity for castration resistance? And it's still being debated. We're sitting on the fence here. We're working with one of the proponents and guys who has really pushed this forward, a guy named Scott Dem, and we subsequent to this, following this work, we've entered into collaboration with. So we'll see where that goes. But nevertheless, we took the viewpoint that maybe there's something we can target there. Again, the hammer looking for a nail. And so look very closely at the DNA binding domain, because for even this splice variant constitutively active form to be active, it has to have a DNA binding domain. And so we looked at the interface of that with the DNA and found indeed, if I can get the arrow there, a pocket. This is a pocket on the protein. Now, whether this pocket's formed when it binds to the DNA or it's always there, we don't know. But certainly it's a pocket that we were able to take ART's virtual in silico analyses, and indeed came up with some chemicals. Now this is our flow chart for doing this. We have the in silico modeling rather. Again, we look for activity, inhibition obviously, for our transcription, our PSA. And in this case, we want it to be inactive. We don't want it to bind to the ligand binding domain. So at the moment, we're looking for things that don't bind. And then, how do you guys use this? We put it through all the different assays for activity and so forth, and again, medchem. Now, these are some of our, right out of the box, so to speak. If you recall, the BF3 compounds, they were the first starting compounds in terms of their IC50s were around 600 or nanomolar, or 0.6 micromolar. These are even more potent. The top few, and particularly this one lead one, is potent at about 0.2 micromolar. So these are binding to the DNA binding domain. I'll show you some of our evidence for that. They are effective in inhibiting both the transcriptional assay and the PSA, the endogenous PSA. They don't, or very weakly, displace DHT, and they don't bind to the ligand binding domain. So they meet those criteria. Now the cell survival, the MTS assay, if you see the purpley pink things, that's the resistant, the enzalutamide resistant cells, okay? And the black spots are the LNCAP, and the PC3 is green. PC3, again, no AR, no effect. But with these drugs, these DNA binding domain drugs, we can attack the resistant lines, the enzalutamide resistant, as well as the LNCAP quite effectively. Now, if you look down below, what's shown there is a comparison. Now, this is done differently. There we take the PC3 cells, we transfect in either the full-length AR or one of these truncated variants. And the most prevalent reported truncated variant of the AR is called the V7 variant, okay? And as you can see, the red curve shows the effects on the variant of our drug. That's a cell line that only has the variant, and we're able to quite effectively inhibit it, and then the wild type as well. So these compounds will effectively target any form of AR. Very broad spectrum and very valuable, especially if these variants prove to be a major player. Now, how do we know it's binding where we think it is? We're not using the BLI at this case, so we can't really say we're sure it's binding to the AR, other than it has no activity in AR negative cells. So what we did is perform point mutations in the site where we modeled. So these are different point mutations that were put in there, and what we're looking for is a mutation that will knock out our drug, but not knock out the AR. Okay, so here's the comparisons here. This is the wild type AR, and this is what happens when we add our lead compound. This is mutation 1, and so the mutation 1 has no effect on our lead compound. Mutation 2, however, though, still quite active in terms of without the drug, but with the drug, our drug has no effect. And so and the same is with mutation 4. So this, for us, validates that the site to which our drug is binding is indeed encompassed by at least these two mutations. Okay, so this is our way of showing that it's binding where we think it's binding. Okay, so I've tortured you enough with a lot of biology. The main conclusions are that we have we've developed these assays, several assays to validate our in silico screening. Some of these assays are being spread all over the world now. I mean, you'd think it'd be fundamental to measure some of these things, but it's not. The cell lines that we've created have been going everywhere. We have potent AR antagonists rather, that bind to the DNA binding domain. These are the newest and greatest. We also have the BF3 ones, which are further developed and hopefully will be more into a clinical setting sooner. But the DNA binding ones have the value or the the factors that it will inhibit any form of androgen receptor, whether it be truncated, constitutively active, or not. So now we're doing medicinal chemistry to create not even more potent derivatives, but really derivatives that work very well in vivo. Because in some of our early experiments, when we do the pharmacokinetics and pharmacodynamics, they're not great. They're okay, but they're not great. And that has to be improved. And recently, we have a CSER grant, which is for commercialization of research, and some of that will apply to trying to do the medchem, because it's not a cheap proposition to do that, and it's hard to get funding from grants for that. And hopefully, owing to their unique mechanisms of action, these new AR inhibitors should increase the survival of men with castration resistance. So my final slide, or semi-final, is showing all the contributors. I won't try to name them all. We've been extremely successful in getting grant funding, and you can see the various icons there indicating who has funded us for this type of project. And I have to give kind of Safeway credit. They really got it going and continue to support it, which is great. And finally, everybody else. This is for Larry, but it's an old picture, Larry, as you mentioned, but you're the captain on the team if you can find yourself in there. So thank you very much.